TMJ and ENT specialists, but very often gets missed as a cause, particularly if there's no inner ear problem found. Misty vision, wafty headedness, disequilibrium. They say I don't get gross vertigo, but when I turn my head quickly, the world sort of follows a split second later. I'm unsure of stairs. I just feel unsure of myself. And they very often get tinnitus and hyperacusis. Just to remind you of the anatomy, the most important area is up here, C0 to C1, 2. These three groups of muscles just here have nearly 1,000 times more proprioceptors in them than any other muscle of the cervical spine or the rest of the body. This is the gyroscope, if you like, of the whole of the body. And a lot of evidence is showing that it actually sets the posture for everything beneath it. So the ground reaction force they pick up from the feet is then set and reflected by what these things are picking up. That's why when you see scoliosis patients, it doesn't matter how twisted they are, their eyes will always be on horizontal, because this detects it and sets the neck accordingly. The major one that isn't particularly noted on that slide, I'll just move on to the next one. The interesting finding that I'd like to have changed in the radiological world is this, the loss of the lordosis. How many times do we read on an X-ray or a spinal MRI like this that the loss of lordosis is due to muscle spasm? It's complete rubbish. The loss of the lordosis is in fact due to muscle shutting down, not the opposite. Most of the injuries in posterior whiplash causes damage to a small muscle here called rectus capitis posterior minor, which actually has a small fibrous bridge that attaches to the dura. That's a major finding because its process is actually to hold the dura back during flexion extension movements. If the posterior muscles are damaged and they atrophy, the C1-2 complex actually shifts forward into extension. The mechanism by which that happens then sets off shutting down of the anterior cervical muscles and the posterior ones, the deep multifidus stabilizers, and they very quickly become uncomfortable. Very often they don't get any pain up here. They will tell you the pain is all around the facet joints of C5-6 and C6-7, and very often in a lot of other MRIs the classic is the loss of lordosis and C5-6 disc bulging. The disc is not your problem. The disc is the effect. The problem is up there. Very often we'll treat endlessly the C5-6 disc, which has become hypermobile and being overused. You're recruiting a range of movement that should be done up here. 50 degrees of rotation comes from C1-2. 50 degrees, that's almost all rotation. The other facet joints down here are not designed to rotate. So if you start recruiting them, things break down. This is another example. Again, these are just more images of this flattened lordosis. But the consistent sign you'll also see is actually extension at C1-2. This is locked in, and that becomes basically blocked in its movement. And that is what I treat. It's that simple. The trouble is if they've had it long enough, they get the secondary changes. This is just to show that little cross bridge that comes across from the back of the muscle. And if the forward head posture of laptops, etc., becomes exaggerated, this actually shuts down. It is not used to extend the neck. It's used to govern and monitor movement of the C1-2 complex. So it has a very, very specific. Again, this is more anatomy, I won't bother you. These are the muscles that shut down. This is the anterior aspect of the cervical column, and these longus colli muscles are the ones that settle down. You can also see with the superior cervical ganglion how much sympathetic involvement anatomically and how important these are, which is why you get feed in centrally to the brain and you get all the other strange associated symptoms. Again, more anatomy, which I won't bore you with, but very often you also get involvement of the C2 nerve root here, which also can give you a C2 headache, which is again the side of the face, etc. And that is due to the extension of the neck, upper neck complex actually impinging on and functionally irritating that nerve, and that's the distribution of the headache. It's very often seen as a greater occipital nerve irritation. This is just to describe again the forward head posture. It's quite an interesting statistic that for every 1 inch of the centre of line of gravity that the head moves forward with bad posture, the head actually weighs 3 times as much biomechanically. So immediately you're putting all the structures of the neck, the muscles, etc., under massive increased load biomechanically. This is a phenomenon that a guy called Jander in Australia, who I used to work with, described, called the upper cross, which is that basically after long-term changes in their posture, particularly in the upper cervical region, they begin to completely shut down their postural mechanism and simply use phasic muscles. These are fatigable muscles, which is why people who have the fibromyalgia, the chronic fatigue, etc., all come in with these very painful muscles we can all press and find trigger points in, because they are not tonic muscles. They're not designed to have long endurance capacity. They are fatigable muscles that tire very quickly. This is just, again, the neuroanatomy to describe very quickly how the trigeminal ganglion here takes in all of the information for the head, neck and face and positional information, but correlates it with the input from the C1, 2 and 3 levels from the mixed spinal nerves, which is then mediated up through the trigeminal thalamic tract. Interestingly, it also bypasses through the thalamus, which, as we all know, mediates pain. There is another I haven't seen much of this, but it's quite well documented now. You can also get a neck-tongue syndrome, where similarly the hypoglossal nerve becomes involved through its connections with C2 and C3 mixed nerve roots, and they get disordered apprehension. They get slight changes in their speech, articulation, if you like, but they also get a numb tongue, which again can often mimic some very serious, obviously, intracerebral problems. I won't bore you with this too much, but these are the pathways by which the neck feeds in intricately with the vestibular nucleus from the inner ear, and also obviously with the other pathways that come in from the feet posturally, but also from the eyes. Most people who will produce this syndrome also become, because of computer work, massively over-dominant on their visual cues. They are beginning to balance by what they see, not by what they feel. And the problem with that is that they immediately, as soon as they get up and do activities, the eyes are confounded because now everything is moving. And remember, one important thing is that the vestibular apparatus in the ear only registers gross deflections in head movement. That's why we do the Hall-Pike test, these great big movements. When they're doing small head movements where the head doesn't turn, the vestibular apparatus almost switch off effectively. So you're relying on your eyes and your postural receptors. If they don't link, then you get dizziness. It's that simple. And unfortunately, we're seeing more and more of it with people spending too much time at computers. Again, this is just shows the mediation between the cervical muscles, etc., and how they feed in with what the eye is telling you and what the spindle fibers, vestibular apparatus, and the joints of the neck feed in. And we're beginning to learn more and more about this with imaging and obviously with greater technology. This is just a list of the amazing reflexes that exist between how you position your eyes, your head, your neck, how we actually stand up, how we follow moving objects. Again, I have a patient at the moment who only has problems when he's actually trying to play football or a ball game, because he has a mismatch between what his eyes are telling him and what his neck's telling him. Treating his neck and giving him techniques which ask him to rely much less on his eyes, balance techniques, core stability, has massively improved and got rid of the problem. But he has seen 21 different people before he found out that this correlation. And this is where I'm saying about the whole subspecialization. The neurologists are far more interested in structural problems relating to obviously his software. The orthopods can't find anything that's sticking into anything, and basically they need somebody who can link the two. And that's really, I think, where we fit in. Lastly, these are just some of the little tests that we do. You can see this lady's doing the stepping test, and she's also got her earmuffs on because we want to remove any form of hearing stimulus, and the eyes shut. Believe it or not, we reckon that 40% of people now cannot stand on one foot with their eyes closed and balance on one foot for more than 30 seconds, which is a big worry, particularly the elderly. Looking at osteoporosis, I would argue strongly to say stop worrying about the bone density and stop having them falling over. The reason they fall over is because their necks degenerate and they begin to get the dizziness problems, which then obviously feeds into everything else. But these are just some of the tests we can do. Again, I can happily give anyone a list of these tests. They're very simple to do. You can do them in the clinic. You don't actually have to use the muffs. That's icing on the cake. But it's very easy to do and very easy to read, and will help you make a diagnosis, but also an easy referral to who you think would best treat them. This is quite an interesting little one. Obviously, our feet are ugly things to most people, but they're probably the most important relationship we have with the world, in that they give us all the feed-in information from gravity and our complex involvement with the ground. This is a little test where you simply just push your patient very gently, and as they claw their toes to balance, this is a normal reaction where in fact they claw the toes. The most abnormal reaction is they flatten them and give themselves hammer toes, and that is in fact disordered vestibular information coming through from the feet, and it's a very clear sign that they're not linking their brains really with the rest of their body. This is another nice one that I actually like doing. We actually put a laser pointer on the top of their head. We ask them to put, you don't have to wear the earmuffs, but they target it as closely as they can on the target. They then simply close their eyes, look away, and try and resituate it with their eyes closed. We give them a 3-inch leeway either way, but people with this disorder will be grossly off and be really bothered by how how difficult they find it. It's actually an easy one they can replicate at home. You can give it as an exercise, and it's amazing. Within 10 days, they can get it back to normal. What we also see by treating it, rehabilitating it, and getting their vestibular mechanisms back again is that we can actually get the lordosis back. This is a gross example in that she's already had the disc replacement, unfortunately, before we saw her, which is sad because it was probably unnecessary. She had the loss of lordosis, and despite what we've done surgically, you can actually see there's quite a nice, and there is actually a third picture where you can actually see the lordosis has responded very nicely. The multifidus has switched on and is holding her in a much more advantageous position. And interestingly, all her pain from this facet joint, which was really coming from the fact that she was jacked open by the disc replacement and stretching the capsule, has now much improved because effectively the facet joint has closed down again. Dynamic imaging, why it's really important. This is a dynamic MRI, which are very useful. Unfortunately, though, we can only really take flexion extension movements. But it is quite interesting because you can see in flexion, the discs actually do the opposite of what we expect. They actually pop back in relatively as the head is flexed forward, whereas in extension, not only is there not very much extension, but you can see the discs actually pop out again at several levels. So again, imaging is really beginning to not only confound but help us clarify what really goes on in the neck. However, rotation is usually, and side bending are usually problems that most patients actually complain of. Flexion extension are less important to patients very often. This is taken at the ESC scanner. I love this picture because this patient has got everything. He's actually hypermobile, which is a big problem to him. He has all the vestibular stuff going on. I call it vestibular, let's call it dizziness, giddiness. But more importantly, his MRI actually was recorded as normal. As you can see from this is the anterior aspect of the cervical spine. You can see here is his C1, there is his dens inside. He has a grossly dysmorphic C1-2 complex. I don't know if you can see that, but there is a normal facet joint on the right there. And the left one is actually twisted right off to the left, and his C1 is actually sitting rotated to the left in a normal position. If we activate the... Oh, sorry, hold on. This is rotation right, okay, and we keep doing it. You can see, and in the next one, which I'll show you again, let's just keep doing it for a second. You can see how, unfortunately, I've done it again, sorry. Technology. This is now looking from above, as Simon said, we can orientate. That is the same scan, and we've simply flipped upside down, and now we're now looking down him actually, so you can see deep inside his neural canal here. These are the various levels below. Here is the C1 ring. There is the head of the dens, and these are the shoulders, if you like, of the axis sitting on the atlas. Sorry, other way around. But basically, this ring, as you can see, is rotated quite dramatically as normal anatomy. So unsurprisingly, he had a much reduced range of movement in one direction and gross over hypermobility of this facet joint here, which is also slightly beveled. His pain is all underneath that side. He doesn't like rotating, he doesn't like extending, and in fact he's just undergone a denervation for this because nothing's going to fix this in physical therapy. It's a disordered pattern of movement, but a denervation in fact has cured his pain. Denervation is a process by which we knock out the small rhizome that supplies the joint, and very often it has great success, as it did in this case. If we hadn't had this imaging, we would have never found this, because the slices that we have, possibly an oral x-ray, but again it's a three-dimensional image with a two-dimensional facement, so this massively opens up the possibilities of what we can pick up. This is the posterior aspect. This shows it rather nicely. Here are the spinous processes, and you can see this very, very misshapen facet joint on the left end. You can even see the neck of the dens is rather distorted. The shoulders, if you like, of the C2 are very distorted. And again, this shows... Sorry. You can see it there. The left one is dipping right down past, and on rotation the other side is minimal. He's happy to go left, very unhappy to go right. So we've just come in and we've just zapped the capsular nerve that supplies this joint, and basically we've got rid of most of his pain. This is an image that actually Simon showed earlier, but it was a patient